In this video, we'll talk about spinal cord and its clinical implications. Spinal cord is a very important topic for any MD exam, mainly the practical exam, because most questions on spinal cord are asked during the practicals, and you'll get at least one long case on spinal cord. Either it would be compressive or a non-compressive myelopathy. So before understanding pathological processes of spinal cord, let us first know about the anatomy of cross-section of spinal cord. So knowing anatomy will help us to know about the pathology and easily differentiate between compressive as well as non-compressive myelopathy and medullary, intramedullary or extramedullary lesions. So first, anatomy of spinal cord. So spinal cord on cross-section. Okay. This is a rough diagram of spinal cord. Okay. So this is the central canal. Now I'll mark first the ascending tracks and then the descending tracks. So the most important ascending track which we need to remember is spinothalamic tract. So spinothalamic tract has two parts. One is anterior spinothalamic tract and one is lateral spinothalamic tract. So lateral spinothalamic tract is located here. Okay, this I'll label as lateral spinothalamic. It is lateral to the anterior horn cells. Okay, this is anterior, this is posterior. Okay, so the next tract is the anterior spinothalamic. So both these tracts, what they do is that spinothalamic tract, as we all know, carries pain and temperature. So lateral spinothalamic tract is mainly for pain and temperature. Okay, pain and temperature. Okay, anterior spinothalamic tract is for crude touch and pressure. Okay, so these are the first two important tracts. So just see the location. They are located anteriorly, just lateral to the anterior horn cell is the lateral spinothalamic tract, anterior to the anterior horn cells is the anterior spinothalamic tract. Now coming to the next tract. The next tract is spinocerebellar. There are two spinocerebellar, one dorsal to the midline, one ventral to the midline. Okay, so this is dorsal spinocerebellar, this is ventral spinocerebellar. So the function of both this tract is basically unconscious proprioception. What unconscious proprioception means is that joint position sense in an unconscious state. Okay, so the next tract is another important tract. These are called as the posterior column. Posterior column consists of two tracts. Okay, this is divided into, the medial one is called as fasciculus gracilis and the lateral one is called as fasciculus cuneatus. Okay, the function of both this tract is carrying conscious proprioception. The joint position sense, what we test in any joint is this conscious proprioception. The next step is fine touch, pressure and vibration. Okay, so this is basically the ascending tracts. So now coming to relay stations of this ascending tract. So the first area here in the dorsal horn is the relay station for spinothalamic tract. This is called as substantia gelatinosa. Okay, so the next relation would be relation for posterior column. Posterior column relation is called as nucleus proprius. Third relation is for spinocerebellar tract, and it is located here. This is called as Clark's nucleus. Also called as column. These three are not the synapses of these tracts, but these are just a relation where they release one interneuron which is responsible for various mechanism, like interneuron of spinothalamic tract here gives a G neuron. Now G neuron, G denotes the gate mechanism, so the substantia gelatinosa is involved in gate mechanism, that is closure or opening of gate. That is not important currently in this topic, at least. Okay, the next thing what we'll use is we'll use a different color for this. Okay, so this is the dorsal horn. Sorry. Okay, this is the dorsal horn, this is the anterior horn. Here there is one intermediate horn where there are three neurons. Okay, this is called as intermediate nucleus. Which is parasympathetic and sympathetic. So we know sympathetic is thoracolumbar, parasympathetic is sacral outflow. So this is present in S2, S3, S4 region. This is present in T1 to L2. Okay, so, and now coming to the anterior horn. Anterior horn cells are basically three types. So one is medial, one is lateral, one is intermediate. So the lateral, L for L, you remember the lateral nucleus, I'll write it separately here. Lateral nucleus is for limb muscle. Okay, medial is for midline muscles. The intermediate is for diaphragm and spinal part of 11 now. Cranial now 11. Okay. So based on this, only based on this, now if you want to know if any disease process, how it will involve. Okay, so let's use some dark color. Okay, now if there is one lesion here, lesion in the spinal canal, so this lesion is called as intramedullary lesion. So what intramedullary lesion will do, it will expand like this. So what happens is that the fibers from the dorsal column come here, for the lateral spinothalamic come here, travel like this, and anterior to the spinal canal they cross to the other side. From here they ascend upwards. So now whenever there is a lesion here in the spinal column, when it expands, it first involves the lateral spinothalamic tract. So when first lateral spinothalamic tract is involved, what it will do is that there is loss of pain and temperature. Okay, so what happens is that contralateral loss of pain and temperature. Once pain and temperature is involved, so the first thing that is involved is pain and temperature. However, when it expands further, it may involve the lateral intermediate horn. Intermediate horn is what? parasympathetic, sympathetic. Parasympathetic and sympathetic are mainly involved in what control? Bowel and bladder. So once bowel and bladder is involved earlier in disease. So in intramedullary, what happens is that lateral spinothalamic tract is involved early, then involved is the bowel and bladder. Okay, so bowel and bladder involvement is early. So what we can tabulate is that in intramedullary lesions, okay, lateral spinothalamic involvement is early. Okay, bowel bladder is early. Okay, these are the 2 points which we read. The third thing is that when only pain and temperature is lost, but there is preservation of the posterior column, that is this region. This region is preserved. So this region is preserved. This gives rise to a typical type of anesthesia where there is loss of pain and temperature with preservation of joint position sense as well as vibration, which is called as dissociative anesthesia. So typical features of intramedullary lesions are what? Early involvement of lateral spinothalamic tract, early involvement of bowel bladder, involvement of dissociative anesthesia. Now when it expands, it may also involve the anterior horn cells. When anterior horn cells are involved, the predominant feature would be what? Anterior horn cells involved. So what it would cause? Predominantly LMN features. So LMN features are early and predominant. Okay, so these are features. If LMN features are early and predominant, what other feature we'll get is that fasciculations. Okay, fasciculation is a feature of LMN involvement. Okay. Along with fasciculation, what other feature you will get is that pressure changes. Pressure changes in the sense what? There's muscular movement of features like bed sores, etc. are present in intramedullary lesion. Now, in this diagram, I have not shown the descending tract, that is corticospinal tract, which is located here is the lateral, here is the anterior corticospinal. So, involvement of corticospinal tract will occur very late because it is very far away from this lesion. So, involvement of that is UMN signs are late feature. Okay. What are the main features of intramedullary lesion? Lateral spinothalamic tract involvement is early, bowel bladder involvement is late, dissociative anesthesia, that is posterior column is involved really rare. So in most period of the disease, the posterior column is preserved, that is joint position sense as well as the vibration is preserved with loss of pain and temperature, that is called as dissociative anesthesia. Anterior horn is involved early, so LMN features are early and predominant. Because LMN features, there is fasciculation as well as pressure changes, and UMN signs are late features. So this is basically if there is intramedullary lesion. Now if there is an extramedullary lesion, let us draw the spinal cord again. This was our spinothalamic, fasciculus gracilis, fasciculus cubitus. These are spinocerebellar and ventral and dorsal. Okay. Now the main tract here. Okay, this is lateral corticospine, this is anterior corticospine, which Just below this is a small nucleus that is rubrospinal. Okay. The medial and lateral are medial and lateral reticulospinal. It's vestibulospinal. This is tectospinal. Now only corticospinal tract is called as pyramidal tract. Rest all tracts are called as extrapyramidal tract. So an important thing is that just remember reticulospinal tract inhibits anti-gravity muscle. Tectospinal tract helps in movement of the head in response to stimulus. Rubrospinal tract helps in it facilitates the flexor tone muscle tone of upper limbs. And vestibulospinal tract stimulates ipsilateral expansion of the trunk and the extremities. Okay, so now the next scenario is if there is something compressing from here, that is extramedullary lesion, that is outside the spinal cord. So if there is something compressing here, the involvement of corticospinal tract is early. So features of extramedullary will write is that early UMN involvement. So because corticospinal. Now next tract which is close to the corticospinal tract is the spinothalamic tract. So pain and temperature lost early. Now if you see, this is the medial most, that is the dorsal column. Dorsal column is lost late. However, these usually occur together because most of the time the compression occurs in this direction. Okay, so the direction of compression is this. Okay, because the disc is present posterior to the spinal cord, so once the disc prolapses anteriorly, it will compress the posterior portion of the spinal cord first, that is the dorsal column, then the lateral spinothalamic tract and the lateral corticospinal tract. So for dorsal column is also lost. There is no dissociate anesthesia. Now if you see, the bowel bladder is deep, so bowel bladder involvement is a late feature. Okay, bowel bladder involvement is a late feature. Okay, so now it is predominantly UMN, but late stages you will get UMN signs. Okay, this is about extramedullary and intramedullary lesions. Now how to differentiate whether a lesion is compressive or non-compressive? What compressive lesion means is that whether there is a tumor or a disc or the vertebra is impinging on the spinal cord and causing the symptoms. Non-compressive is that either ischemic etiology or autoimmune etiology is directly damaging the spinal cord without involvement of the spine. So whenever there is compressive lesion, like in this case, now suppose if you extend this, here will be a dorsal root, here will be an ventral root or the anterior root. So here will be the dorsal root ganglia and here will be the nerve trunks. Okay, so if there is any extramedullary lesion, it will compress. So extramedullary lesion will cause compression of this nerve root first. So whenever a nerve root is compressed, typically causes something called as root pain. It is a root pain? Root pain is due to compression of the radicle or the nerve trunks of the nerve root, which produces a sharp lancinating pain or sharp shooting pain along the dermatoid. The root pain is exacerbated by coughing, sneezing, or anything that increases the intracranial pressure. So root pain is a feature of compressive lesion. In non-compressive lesion, there is something called as funicular pain. Funicular pain is a deep, ill-localized pain. It is actually not radiating along a dermatoid. It is deep, diffuse, ill-localized, and it is due to involvement of dorsal column or lateral spinal column. Both can cause funicular pain. Okay, so root pain is a feature of compressive myelopathy. Now, as the disease process, as I said here, extramedullary lesion involves involvement of either vertebral column, that is the vertebra itself, or the intervertebral disc. So what will be there is that bony tenderness, bony deformities, okay, which are absent here. Okay, so these are the basic three main differences. Now, three things which are common here are that band-like sensation. Band-like sensation is due to involvement of posterior column. So there is like at the upper level of loss of sensation, there is a tightness in the abdomen or in the chest or in the neck, which can be felt by the patient, which is described as band-like sensation. Above the level of the lesion, there is always a zone of hyper or increased sensation. This is common for both. Okay, girdle-like sensation. This is also common for both. Okay. Now for non-compressive myelopathy, bowel bladder involvement. Is early. Now for compressive myelopathy, if it is intramedullary, it is early. If it is extramedullary, it is late. Okay, the reason I explained here, because intramedullary will go here, reach the intermediate horn early and cause gallbladder involvement early. However, the extramedullary lesion will reach this horn very late, so cause gallbladder involvement very late. Okay, so this. Now another feature is that non-compressive myelopathy. In compressive myelopathy, CSF is usually normal. Yes, CSF can be abnormal in presence of oligotonal bands, etc. Okay, CSF here is normal. Yes, CSF can be abnormal. However, it is not normal in most of the cases. Okay, so this is another feature. So this completes our lecture today, where we learned about the anatomy of spinal cord, intramedullary lesion, extramedullary lesion, how to differentiate them, how to differentiate compressive myelopathy from non-compressive myelopathy. Another feature is that whenever there is extramedullary lesion, it can be intradural, extradural. Intradural could be because of some meningioma, neurofibroma, or due to arachnoiditis. Extramedullary is due to PIVD, vertebral knots, tumor, etc. So all these three, the feature would be it is insidious onset. These are acute in onset. Okay, no bony deformity in intradural, where there is bony deformity. Tenderness present, no tenderness. So these are the differences between intradural and extradural. So this we finished the how to localize lesion in the spinal cord. There are various spinal cord syndromes which